All right,
Okay,
thank you, Dr. Saukinen, for that talk. And our next speaker in the series this afternoon is Dr. Christiani, who is going to speak to us about occupational and environmental lung diseases. Dr. Christiani?
okay, let me just mute this thing, this reminder I'm getting. Okay, thank you, Angie. It's good to see everyone today. And thanks for the opportunity to talk to you today about occupational and environmental lung disease. So the objectives here are going to go over a presentation of common occupational lung diseases you might encounter and diagnostic approaches, and use a few disorders as illustrations, particularly asbestos, asbestosis, silicosis, occupational asthma, and hypersensitivity pneumonitis. And I'll touch on vaping related lung disease at the end. And then also highlight the recommendations for prevention of these diseases. So why is this still important now, given the situation in the US where our economy has moved largely away from manufacturing and agriculture to service? What are we seeing? What kinds of presentations are we seeing? Well, one is these are important conditions to realize because identification of a causative agent or process can result in disease control or prevention in individual patients, of course, but in a also individual patient, persistent exposure and lack of identification can exacerbate and or accelerate a disease process. Thirdly, the detection of a association of disease at work with exposure does provide an opportunity for control and prevention for an at-risk population. And lastly, occupational lung disorders have provided models to study pathophysiology where causes are less known, such as IPF, and using compounds like asbestos and drugs to induce fibrotic conditions. So excluding workplace injuries, occupational lung disease still represents the most frequently diagnosed work-related condition in the US. The population profile of occupational lung disease as far as impact goes is interesting. A few years ago, just before the pandemic, colleagues at San Francisco at UCSF in the Blue Journal presented some very interesting data on the burden of occupational lung disease in the US. And they use what's called a population attributable fraction as a calculation for estimating the proportion of a population with a certain disease that's causally attributable to a certain exposure. So in incident asthma, that is new onset asthma, for example, the population attributable fraction was estimated to be 16%. So 16% of new adult asthma was felt to be potentially occupational in origin. COPD, about 14%. IPF and ILD related conditions, 26%, granulomatous lung disease and sarcoid, about 30%, and hypersensitivity pneumonitis, about 19%. So as you can see, these are not trivial figures, and those are current, not historical. So what are the diagnostic approaches to potential occupational lung disease? They're not different than our approach to any other pulmonary disease and a patient presenting with symptoms that may have pulmonary disease, with one exception. So one is we want to get a definitive diagnosis, of course. Secondly, we need to document relevant exposure history in considerable detail. And third, we need to be aware of the association between that potential exposure or exposures and the condition in question. So, of course, history is absolutely critical. Detailed occupational and environmental history, more than you maybe generally take if you really suspect an environmental or occupational component. And the rest of the tests are similar. So chest imaging is essential for pneumoconiosis, which I'll go over in a moment. Those are the fibrotic lung diseases. It's neither sensitive nor specific, although some patterns emerge that are important. PFTs, of course, are essential in the pulmonary world. Exercise testing we usually reserve for disability assessments after diagnosis when standard PFTs appear to underestimate the degree of impairment, meaning that even for a disability assessment for, say, Social Security or workers' compensation, you can use standard PFTs unless there is a conflict between symptoms and standard PFTs, in which case exercise testing would be useful. So let's talk about some specific lung diseases. So One would be the interstitial lung diseases, pneumoconiosis and hypersensitivity pneumonitis. These are the fibrotic lung diseases. Secondly, with asthma, occupational asthma. And third, I'll touch on latest 21st century environmental disorder, which is vaping-related lung diseases. So interstitial lung disease due to occupational exposures are from the Greek pneumoconiosis, which just means dust in the lung. And they're typically, this is a typical list of the most common in the world: asbestosis, silicosis, coal worker, carbon, mixed dust, etc. And HP is on that list. It's the only one of this list that is not a mineral compound, but is caused by organic material, but with a fibrotic response. So let's spend a little time on asbestos, which still seems to be in our older population relatively prevalent, and decreases as the population ages out. It can cause a fibrosis, a parenchymal fibrosis, an interstitial fibrosis. It also causes a variety of pleural diseases, one being circumscribed parietal pleural plaques. Another is diffuse visceral pleural fibrosis in the aftermath of a pleural effusion. And a third is round atelectasis or pseudotumor. So the interstitial disease due to asbestos looks very much like IPF in presentation. Symptoms are the same. One difference in asbestos versus IPF is that the symptoms can be out of proportion to the chest X-ray or CT readings as far as the extent of abnormalities. The exam, of course, crackles are fairly typical. Clubbing is only seen in advanced cases, just as it is in the IPF. Exercise tests can be useful, as I mentioned before. Rest and exercise oximetry can be useful in the assessment. Chest X-ray shows irregular opacities with a middle to lower field predominance, similar to IPF. And CT scans, the most sensitive, of course, to finding early parenchymal lesions as well as pleural lesions. And they vary with the duration and severity of the condition, largely confined to middle and lower fields. There are central lobular opacities, peribronchiolar fibrosis, intralobular linear opacities, reticulation, and subpleural lines. As the progression of fibrosis occurs, a number of more definite findings are seen, particularly in the lower lobes with thick parenchymal bands. There can be traction bronchiectasis, honeycombing, and in contrast to IPF, pleural plaques are very common in this group. So this individual illustrates all of the findings. There's traction bronchiectasis, thick fibrotic bands, subpleural fibrosis, honeycombing, and calcified pleural plaques, like the one here, and there's some non-calcified ones as well. Biopsy, dense parenchymal fibrosis. Air is relatively spared, and it's very obvious bronchiectatic and bronchioloectatic. That's honeycombing with a thick visceral pleural peel in this case. On microscope, this is just H&E high power. It's the fibrosis pattern is very similar to IPF. The pathologist looks for the presence of asbestos bodies in the peribronchial space, like here, and the group of them here. And that is what nails the diagnosis for asbestosis, the presence of one or more asbestos bodies, which is a coated fiber that takes years to develop this iron-laden coating to the, so if you did iron stain, you'd see an iron-rich stain in the area of the of these asbestos bodies. Here it is at high power with macrophage, a couple of macrophages trying to ingest it. For every one of these free fibers, there can be 10,000 to 1 million uncoated fibers. So this is why one or more indicates usually occupational levels of exposure. Pleural fibrosis or plaques is very common in this condition. The most common is circumscribed pleural parietal plaques, not visceral plaques. They're acellular, they're eosinophilic, usually bilateral and symmetrical, lower fields, usually asymptomatic, and not impairing. A very small minority can have a restrictive defect from extensive circumscribed plaques. The calcified will be obvious on CT scan, like these in the lower fields posteriorly. And the most dread pleural complication of asbestos exposure is a malignant mesothelioma of the pleura, and it can affect, of course, the peritoneum. And asbestos still remains the #1 cause of mesothelioma in North America. That particular tumor has no relationship to smoking. They can present usually with, they're always symptomatic, mesotheliomas. They're not asymptomatic. It's going to be chest pain, dyspnea, weight loss, and pleural effusion is very common. And on draining a pleural effusion, a lumpy, bumpy pleura is very high suspicion for mesothelioma, as it is, of course, for lung cancer or metastatic lung cancer. Lung bronchogenic carcinoma, such as this one here, is elevated in asbestos workers, asbestos exposed workers occupationally, particularly in those who smoke, where there's a biological and statistical synergism, a multiplicative interaction. So on a follow-up study that went on for many years in the New York, New Jersey area, started by Selikoff and a paper by Steve Markowitz in 2013 that updated it, showed here the relationship between smoking, of course, a tenfold risk of dying of lung cancer. Asbestos approaches 4. Smoking plus asbestos exposure about 14. So that's additive, but in the presence of asbestosis, which implies more heavy exposure, it's multiplicative. What about screening for lung cancer in asbestos exposed workers? Well, the cumulative risk in this population approximates the level of risk endorsed by the guidelines by the Preventive Medicine Task Force, revised in 2021, revised and updated. That means those age 50 or more who smoked at least 20 pack years. And I'm sure this is discussed in other talks for lung cancer screening. There may well be additional lung cancer factors in this group, including the occupational details of their exposure that could broaden the above criteria, but the data are lacking right now. There have been populations I've seen where their insurance company does cover screening in asbestos exposed workers who've been exposed more than 15 years ago and occupationally and not trivial levels of exposure. That is more substantial regular use of exposure more than 15 or 20 years ago, regardless of smoking habit. But in general, just follow the preventive medicine guidelines in this population. And of course, they shouldn't smoke. This is just this is from a very recent picture of a building that's was completed. So these are substitutes. What you see these days in buildings going up, and you might see it in your own hospital or institution. This is what sprayed on asbestos used to look like. This is not. This is a substitute. It's mostly calcium derived products, and it is not asbestos. It's dust. It can be dusty if it's scraped off, but it's not. It is not dangerous. It is the reasonable substitute for fireproofing these days. So you will see this from time to time. And so we have patients, and we'll bring in pictures, and you'll see if the building was built since 1973 as a new building, it will not have sprayed on asbestos in it. Okay, let's move on to silica, something we thought we had beaten in the past, but seems to come back like some other problems in environmental health, like lead, and just seems to keep popping its head up. So silica is SiO2, a very simple molecule. It's quartz. It's found in a number of conditions, other working conditions, and it can be quite dangerous. It's very fibrogenic, it's carcinogenic, and it has some protein immune manifestations. So sandblasting, such as paints off bridges and other metallic structures, granite cutting and polishing, construction use, boiler lining, mining, and more recently, and I'm going to talk about it briefly, is kitchen countertops that contain silica, may well be responsible for a new epidemic of silicosis in this country. So this is silicosis in a 56-year-old man who worked as a stone cutter, gravestone cutter in Vermont, and you can see the obvious nodularity, various sizes. They're often very small, not where the arrows are pointing, but much smaller. As they coalesce, then it's where the arrows are pointing. That shows coalescence and more progressive, towards progressive massive fibrosis. So this is not a hard diagnosis to make on biopsy, a classic silicosis, in this case, just an H&E stain and using a polarized light. So if you put in the polarized lens, the silica, the quartz itself is negatively birefringent. So you can see the black arrows, or every one of these sort of neon looking lights are silica particles. They occur in these nodules that are not granulomatous nodules. Although on the CT scan, they might appear to be sort of like granuloma, but on biopsy, you can see the picture is not one of a typical granuloma, but it is a nodular disease. And one of the complications of silica exposure and silicosis in particular is tuberculosis and non-mycobacterial infection, non-mycobacterial TB infection, atypical TB. So here's a case with a cavitating lesion in a silicotic patient. Probably all three of these lesions are TB. This one is cavitating. And you can see it's not an extensive amount of silicosis or fibrosis in the area. This is responsible in many parts of the world for the death in silicotic patients. But in this country, we see both atypical mycobacteria as well as TB in silicotic patients. And as you can see, some of these workers can be pretty young, and if they've been exposed heavily enough in early years, the latency period for the development of the disease shortens with heavier exposure, and so manifestations of disease can occur even relatively young age. This is PMF, or progressive massive fibrosis, where those nodules coalesce into large masses, who worked in a coal mine and had exposure to both carbon and silica, which can occur in any mining situations because of the disruption of rock. And you can see that the PET CT is hot. The person does not have cancer. The nodules in silica can be read out as relatively hot on a PET CT scan. This is a case of, you can see the crazy paving. I think it's pulmonary alveolar proteinosis, and you're right, but it happens to be due to silica, acute silicosis, which can induce a PAP type of picture after very heavy exposure. These are not subtle histories on exam. This is after very heavy exposure, like tunneling or cutting tops or a stone, but with very heavy, with no protection over a period of time. And then presentation with PAP-like syndrome can occur. We don't see much of this, but we're starting to see some cases because of the countertops. This is what it looks like on biopsy. And again, it's pretty much, a lot of it's indistinguishable from PAP, except you will have on polarized light a very large number of silicotic particles in there. So our latest problem with silica is in artificial stone. And this artificially engineered stone is a finely crushed rock and then mixed, reconstituted with polymeric resins, and then molted into slabs and heated. And unlike many other stones, like curbstones, building stones, blue granite, sort of fancy stonework, or even gravestones, this material can contain up to 95% quartz. Gravestones can run 40 to 60% from Vermont granite. So this is extremely dangerous material. Once it's molded, of course, there's no dust at that moment, but then they take the slabs, bring it to houses or homes that they're going to be fitting it, and they start cutting it. It's cutting holes for the utilities, and for whatever needs to be done on the countertop in the kitchen. It first became commercially available back in the 80s, but its widespread use has really been only in the past 10 years or so. First case reported in 2010, and reports of cases have been increasing ever since. This is what it looked like. And this is a high silica containing quartz countertop here, and it'll be all along kitchen. Many of us have these in our kitchens now. So California took steps a year or so ago to alert the medical community and to the state OSHA to adopt emergency temporary standards to protect workers who are working with this material. Now, a lot of it is produced abroad as unfinished work, and it comes pretty much locally. So if you're ordering these and your patients are ordering these, are working locally with this, it's because the orders are coming locally, and they take the slabs and have to custom fit it to the kitchens. Therefore, they're doing cutting and sanding virtually anywhere in the country or people are remodeling kitchens, because they have to actually go take measurements in the kitchen itself. And there's usually a shed nearby. I've seen them outside of Boston with actually not good environmental control. So this is unfortunately a condition that's sort of raising its head again when we thought we'd pretty much conquered it with controls. This is bluestone. It's kind of typical of certain regions, particularly upstate New York, not quite into Vermont. And it also can contain substantial amounts of silica, 40, 50, 60%. And it's for patio stones. And so again, power tools, cutting and polishing will generate a lot of dust. You do have to worry about environmentally as well, but mainly for the occupational setting here. So moving on then from pneumoconiosis to asthma, I want to sort of start with a definition. Occupational asthma is a reversible airflow obstruction caused by workplace exposures. And there are two major kinds, those with a sensitization period or latency period, and those without a latency period or with a very high irritant exposure, non-allergic, non-sensitizing exposure. There is also occupationally aggravated asthma, which all of us in medicine have probably seen. That is established asthma that's generally under control, but can be exacerbated by exposure to sensitizing or irritants at the workplace. The actual incidence for this is not known. Prevalence is probably 5 to 15% of adult asthma. I mentioned before the population attributable fraction from the study from our colleagues in California that put it also probably a little higher than that based on the 2019 study. It's hard to actually know the true incidence because many patients become sensitized to material during their early period of employment, during probation periods or periods where they may leave if they start to get symptoms. So the workplace is constantly turning over, selecting out for healthier or more resistant patients. Some agents, such as isocyanates or urethanes or polyurethanes, result in a very high proportion of asthma among exposed subjects using the paints or stains that are polyurethanes. Once the floors in homes, for example, are stained, it's not harmful, but it's when it's used wet and it dries or it's sprayed on and it has to dry, there are considerably high exposures and it's very sensitizing, at least 1 to 2% per year. So 1 to 2 workers per 100 per year. Now, occupational asthma is a broad, the causes a very large, broad group of vegetable, animal, chemical, and metals, sometimes referred to as asthmagens. It's too hard to remember them all, but there are some categories to keep in mind because it relates to its pathophysiology and symptoms and presentation. So one is the high molecular weight compounds, another is a group of low molecular weight compounds, and then the third is non-sensitizing at all, which is irritant gases, vapors, fumes. So examples of the high molecular weights are usually above 5,000 Daltons. Some allergists will say above 1,000 Daltons. Protein polysaccharides, animal dander, lab animals, pets. Then there's Bacillus subtilis, which was used in detergent enzymes for cleaning surgical instruments, beans, vegetable gum, latex antigens. We used to have a big problem with latex gloves and powdered latex gloves. Low molecular weight compounds usually under 1,000 Daltons. Elements such as platinum and nickel used in electronics and jewelry, epoxy resins and glues, isocyanates, as I mentioned before, and formaldehyde, and glutaraldehyde. Irritants would be strong acids, strong bases, and smoke itself. So pathogenesis, of course, on the latency or a latency period or sensitizing asthma, it's usually an IgE or IgG response or more complicated mechanisms. The irritant model of asthma is not at all related to sensitization. It's really an injury model, injury to epithelial inflammation of subepithelial mucosa. So how do you diagnose? Of course, you need to establish asthma. You can't diagnose occupational asthma if the person does not have asthma. So history, document reversible airflow obstruction, sorry for the typo, it's not destruction. And then the exposure disease relationship based on literature needs to be made. You can use serial peak flow measures, very simple, cheap device we use to monitor our asthmatics. You can use it as a diagnostic device. To the left, this is an individual with occupational asthma before and during and then after exposures where it's out of work, establishing a baseline in the upper part with the normal diurnal variation. and then at work with accentuated amplitude during the day of peak flows, and then off work again with the resumption to normal diurnal variation. So that can tie the symptoms and to work. It doesn't obviously identify agent, but it does identify work as a problem. This is a good illustration of the kind of varied presentations of occupational asthma. This is based on challenge tests of a 3-minute challenge with a known antigen in 3 different patients. So on the Y is FEV1 percent, and on the X is time. Oops. So the blue line, typical immediate hypersensitivity response. After 3 minutes exposure, no further exposure, FEV1 drops right away within 15 minutes and slowly recovers over 90 minutes to several hours. And that's our typical immediate hypersensitivity response. The red line is a delayed response only. So exposure takes place at time 0, no response for 3 hours, 2 to 3 hours later, but the maximum response 4.5 to 6 hours later. And this is in certain low molecular compounds, this is the case where it takes time. It's not an IgE reagent response or a haptenic IgG response, but it's a T cell response, requires time for recruitment of those cells. And so you get a delayed response. The person may already be home, and assuming that the problem is something at home and not at work. Both the patient and the doctor might assume that. The green line is a dual response, single 3-minute exposure, no additional exposures, a drop within 3 minutes, 15 minutes, a partial recovery after an hour, and then a second drop, second nadir, going 4.5 hours later. So again, that happens more commonly with low molecular weight compounds. That's a dual phase response. So you have to watch that when you're thinking of the diagnosis and the history. So of course, here management is removal from exposure, strict removal, unfortunately, for those who are sensitized, and treat symptoms and airway obstruction as you would any asthma condition with the pyramid of meds that we use. And then there needs to be a process of job change. People can really not go back with respirators once they're highly sensitized to certain compounds. After the irritant exposure, they can. If there's guarantees they're not going to have very high or severe overexposures, which started the whole process with them. Half of people removed and treated workers do develop chronic asthma, particularly in the sensitizing group, but I've seen that same estimation, same proportion in workers I see with irritant-induced asthma, strong acids, strong bases, smoke inhalation sometimes, vapors from cleaning products. Prognosis is worse if exposure continues, even with attempts at personal protection, and continued exposure, of course, can be fatal, particularly in those who are highly sensitized. So then moving on to HP. So hypersensitivity pneumonitis, also referred in Britain as extrinsic alveolitis. It's an immune-mediated, non-IgE mediated inflammatory pulmonary disease as opposed to asthma, and affects mainly the interstitium alveoli and terminal airways. And this is caused by repeated and often prolonged exposure to organic dust and certain chemicals. There are chemical pneumonitis or chemical pneumonitis that have a hypersensitivity component, not just direct injury. So I know Rachel Knight's going to speak in detail about this condition. I'm going to talk about some of the exposure aspects. So the causes of HP are varied. I'm not going to go through all of them, but there's the broad categories of bacteria like thermophilic species and in composting material in agricultural areas and even in compost near cities. Humidifier contamination with bacillus and with Klebsiella. Machine operators' lung with bacteria and used in machinists, coolants, fluids, and there's fungi, amoebae, animal proteins, most of the same ones that could cause asthma. Many of them can cause HP, and same thing with rodent antigens and lab workers who are more likely to get asthma, but some subgroup can get HP. Drugs, this means in the pharmaceutical industry, so we know certain drugs are dangerous for patients like amiodarone hypersensitivity lung disease. But of course, the workers who make the drugs can get allergic to them as well. And I mentioned isocyanates. It's the most common chemical cause of occupational asthma. So a subgroup of patients with isocyanates can get HP, as with anhydrides are used in the electronics industry and some other agricultural products, such as coffee workers and tobacco growers. So it's a very broad group of exposures that can induce these kinds of reactions. The three clinical forms that are defined historically by nature and intensity of symptoms is still useful, even though, and again, I'm sure Rachel will go into it, when think about the pathophysiology and the diagnosis and treatment options based on the profile, immune profile. But it's good as a clinician to think about the three kind of presentation forms. So one is the acute classic HP, the other is subacute, and the third is chronic. So acute is a flu-like syndrome presenting with dry cough, dyspnea, chest tightness, fever. It really looks like, because the film is abnormal, it looks like mycoplasma pneumonia in a youngish worker. Symptoms usually get better spontaneously. If they show up in the emergency room, they'll get erythromycin and be sent home and will get better. They're usually patchy infiltrates, sparing the apices, no effusions. And in between attacks, because these usually do happen again since people are re-exposed, chest x-ray exam and symptoms are negligible. Again, pleural effusions, calcification, cavitation, nodule, solitary nodules are not present. Fine nodularity is usually present. So here's the ground glass looking, no pacification, and acute HP. And PFTs are usually not done acutely, but if they are, can show you usually a restrictive pattern, usually a decreased TLCO and desaturation on exercise. There is usually a high white count, a mild decrease in lymphocytes peripherally, and eosinophils and IgE elevation are uncommon unless the person happened to have concomitant asthma, which is pretty uncommon in HP. So the differential can acute, of course, acute pneumonia, and if it's in the proper environment, the farm environment, grain dust workers, it could be an organic dust toxic syndrome, chemical pneumonitis, or occupational asthma, all of which will have pretty clear presentations on history. Interstitial inflammation is characterized as acute HP, and it does resolve. They get poorly formed granuloma in the interstitium. You're not going to be biopsying acute HP, so you won't be seeing this. Although subacute, you may well see it. And if you do, the pathologist will call them as poorly formed granuloma, not well formed, and certainly not caseating, so not sarcoid. So subacute cough, dyspnea, fatigue that will progress over days to weeks. This can culminate in severe respiratory distress, and they can start to lose their febrile symptoms, the systemic symptoms, when they start to have subacute HP. PFTs can be mixed, is one of the most common pictures, and they can have a methacholine positive test, but usually do have an abnormal film. So there's no real reason to do a methacholine because they're going to have abnormalities on film and on PFT, so it should not really be in the standard test battery. So subacute, obviously, you're not going to be doing methacholine on somebody like this. Again, a lot of GGO. Chronic is the most insidious, difficult to diagnose. Weakness, anorexia, weight loss, fibrosis on film. And so this has gotten far enough where the antifibrotics are unlikely to have an effect, which is why it's very important to get the diagnosis right. In acute HP, they're exquisitely sensitive to steroids. Chronic HP should still be treated with steroids, but they are good candidates for antifibrotics at that point. And for subacute HP. For chronic, of course, you do what we can, but they're going to have the least potential response because it's gotten pretty advanced. So history, chest x-ray, CT, it's good to do serum precipitants, although they most often come back negative. And if they're there, they do indicate sensitization, but not necessarily disease. PFTs, there is still a role, although it's potentially tricky with concerns about liability. There's still a role for using specific challenge tests to induce the acute response in people with acute recurrent HP if you have a suspect exposure. But it's very hard to find the conditions properly to do that, although they can certainly go back to work with close observation if you're concerned about an occupational exposure, and then see if they get a response. Same thing with the bird keepers at home. And again, I'm sure Rachel will talk about that. You re-expose them and they get sick, you pretty obviously have a exposure connection to the disease. BAL is usually CD8 positive, but a low CD4/8 ratio doesn't exclude the diagnosis. Chronic is very bad, just as in any chronic IPF, honeycomb and traction bronchiectasis, central lobular nodules, and again, a poorer response. Now, a related condition is machine workers' lung, where mycobacteria, atypical mycobacteria, contaminating the coolants used in machining in the Midwest was related to outbreaks of hypersensitivity pneumonitis. And it turned out that these were being aerosolized when using the water-based and non-petroleum-based machining fluids, with contamination and repeated use of biocides that killed bacteria, but not enough of the atypical mycobacteria. Once there's described and exposure stopped with some steroid courses, patients usually recovered. So management, again, is like in asthma, is the absence of antigen exposure, oxygen. Steroids, especially in acute HP, is usually dramatic response, almost like a clinical diagnostic trial. And then the antifibrotics, you can I'll refer to Rachel's talk about some of the details on that. So lastly, I want to go through vaping. The acute severe respiratory distress outbreak occurred in the fall of 2019 and ran right into 2020 as COVID broke out. So cases were occurring concurrently with COVID and presenting similarly with ARDS pictures. Where lung biopsies this is in the 2019 group, showed, and this is in 4 young males, you can obviously see from the biopsies that they're all abnormal, and they all had one thing in common: was accumulation of foamy or vacuolated macrophages in peribronchial air spaces, which is often a sign, foamy macs are often a sign of an injury to the lung, external injury, environmental injury, inhalation injury to be exact. Turned out with additional investigation that year and into the next year that the acute syndrome looked like it was largely due to vitamin E acetate in 48 of 51 BAL samples, but it was still unclear whether it was alone or the heat products of the vitamin E that were actually causative there. So with the acute outbreak waning with public education about adulterants in vaping fluid, mostly cannabis, some nicotine or some mixed nicotine, cannabis, and vitamin A. With Lita Herreri and myself and our team at MGH, we actually started to collect cases of chronic vapors. And so we published a case series of chronic lung pathology in those with a 3 to 8 year history of e-cigarette use in patients who were long-term ex-smokers and started to vape. And we had biopsies, CT scans and biopsies in these. Long story short, a number of them had abnormal CTs, and upon cessation of exposure, 1 or 2 actually improved, and a couple stabilized. But they were on lung histopathology, they all had evidence of constrictive bronchiolitis. And Lita has her approach of optical endobronchial optical coherence, and on the top is a normal airway, and B and C are vaping cases that display a couple of problems. One is small airway centered fibrosis, some luminal narrowing, some luminal obliteration, and regions of peribronchial fibrosis. Further than that, Lita did some staining on these, and on slide E, the lower left, MUC5 expressions of non-smoking former smoker is shown as a control, and you can see there's very little MUC5 expression. The 4 cases above were our former smokers who were actively vaping, and they all showed increase in MUC5 expression. So there was now evidence for small airway-centered injury with fibrosis. There's marked overexpression of MUC5, and of course, some exposure heterogeneity leaves still some questions open to be researched. So I'm going to end here with saying that almost any disease we see in pulmonary, in the differential diagnosis, there can be an environmental exposure. So it behooves us to take careful histories to make sure we include environmental exposures in virtually any of the diseases we're encountering in pulmonary. So with that, I'm going to end. Thank you.